Hello, and welcome to season 4 of the State of Healthcare podcast. I can't believe it's actually season 4. I feel like we've just gotten started, and to be honest, we are just barely scratching the surface of so many issues in healthcare, or just even things that I feel like people should know about. This season, we are talking about autoimmune disorders, the not so hidden epidemic. For so long, these have been labeled a diagnosis of as exclusion, right? So many people were seen as crazy, or they just, were whining about these things that people were like, oh, just push through it. But I feel like now we are starting to realize that so many more people have this, whether we're better at diagnosing or more people are having these particular disorders occurring. It could be a combo. That's what we're going to discuss and try to look into this season. So if you've ever felt like you have this cluster of symptoms, or you don't know what's going on, or you feel like your body is even fighting itself, feel free to tune in. This is kind of a learning process. It's learning how to modulate your flares, learning what that is, where can you get help. So come with me on this journey. Autoimmune disorders, the not so hidden epidemic. Okay, well, welcome back. We are in season 4, which is kind of exciting. It's the state of healthcare, and the season is focusing on autoimmune. But I have Dr. Joseph Brooks with me, and you own all the things with Arizona Specialized Gynecology. I knew I was going to say it weird when I came on there, but so going back a little bit to season 3 with women's health, but also kind of tying it in. So I was going to have you just tell me what kind of patients you work with. Like, tell me about your practice.
Sure. So this practice actually started like about 30 years ago with a doctor named Gordon Davis. And he had done some specialized training evaluating women that were exposed to drugs in embryo that resulted in vaginal issues for them later on in life. And in doing that, he became acquainted with a lot of skin disorders. And so he came to Phoenix and began the practice here, and doing just general OBGYN work, really. But pretty soon, doctors kept sending him their patients that had all these skin issues that they didn't know what to do with. So the clinic kind of evolved into this referral location for patients, for women that had dermatological problems and a gynecological, space. And that's a very, as you can imagine, kind of a small niche in gynecology. Typically in our training and residency training, we don't get trained really well in dermatology. And dermatologists sometimes aren't very comfortable with treating the genital area for different skin conditions. So if you are a woman with a dermatological problem in a gynecological place, it's hard to find providers that know much about it. And so as the practice just evolved that way. And then when I met Dr. Davis in my residency, I saw what he was doing and saw this group of women that suffered with these conditions, and a lot of them were autoimmune. And I got really interested in that and wanted to learn. And so he said, if you're willing to do a fellowship, just extra training after your residency, focusing on this area, I'll teach you, basically. And so that's what I did. And so I started my fellowship in 2006 and finished in 2008, and then have been here ever since. So the practice has actually been here for quite a while, even before me. And now I've been here almost, it's 19 years, almost coming up on 20 years.
To be honest, that's how I found you guys. So when I started, it was because I was referred from a dermatologist who knew about Dr. Davis.
Yeah.
And then I think you were in like
training probably at that time.
At the time. So then I've known you for a while, but we won't date ourselves. But so what kind of population then do you work with?
So I would say the vast majority of the patients that I see are patients that are suffering with autoimmune disorders. Most often it's lichen sclerosus or lichen planus, and there's a few other autoimmune conditions as well. And then patients that suffer with pain with intercourse. I see a lot of those patients, and and then chronic vaginal infections.
Okay.
But that probably makes up a good bulk of the patient load.
Okay. How does that, so for women on the autoimmune side, like, does that lead to more issues of this area, or is it just practitioners don't know how to work with that? Or I guess I'm just curious, like,
It's yeah. So for example, lichen sclerosus, just as an example, it's a condition that is not well understood by the OBGYN community sometimes. And so basically, a lot of women suffer a long time because of misdiagnosis, or they don't feel, they've gone and they've talked to the doctor several times, and they just don't really get information regarding the condition. Even if the condition is diagnosed, a lot of times they're given misinformation about how to manage the condition.
okay.
But in general, patients have seen 4 to 5 doctors before
They
they get here.
Mhm.
So understandably, that's a lot of frustration on the patient's part, and frankly, sometimes patients have given up,
Right.
for a period of time at least,
Um,
because they just haven't been able to get any relief or understand what's going on. So,
no, and I feel like that's also very common for autoimmune, right? They have your
in
visit,
general, yeah.
right? So, pain with intercourse. I know, like, again, it's kind of those things women don't like to talk about.
Can we go back just one
Yeah,
second?
no
I'm
problem.
sorry, because I don't feel like I quite answered that question. So what happens if you don't? What are some of the sequelae of not being diagnosed properly and treated properly with these
Right.
autoimmune conditions
Right.
specifically? And I always tell patients that we treat lichen sclerosus, for example, for 3 main reasons. One, the symptoms, which can just be unbearable.
What
Itching.
is it exactly?
So lichen sclerosus is an autoimmune condition where the immune cells begin to attack the genital area,
Okay.
specifically the vulva. And lichen sclerosus, unlike lichen planus, which is kind of a sister disease to that, lichen sclerosus will stay on the outside skin.
Okay.
And lichen planus can actually attack the outside skin and also go on mucosal surfaces, so it can go into the vagina,
Okay.
or into the mouth. And so when those conditions, specifically those 2 conditions, aren't treated properly, like I was saying, we treat it for 3 main reasons. One, the symptoms. Two, they cause architectural changes. So they can cause the labia minora to disappear, or they can cause the clitoris to be scarred over completely, or the opening becomes really small because of scarring that occurs at the opening, which makes intercourse impossible or very uncomfortable. And the third main reason we treat these conditions is because they are associated with vulvar cancer. Lichen sclerosus is and lichen planus. Those conditions are the number one causes of vulvar cancers.
Okay.
So even in a small percentage of patients who don't have symptoms with those, but they have the condition, they just don't happen to have symptoms, which is a pretty small number, but I see it. Even those patients need to use something, because we're not treating just the symptoms, we're trying to prevent scarring and cancer. So yeah, by not getting the proper treatment,
You're
pretty
setting themselves up for risk for greater things.
pretty significant things can happen that really impact your life, and if nothing else, the quality of life is miserable, if you're not being treated properly. But we really want to prevent cancer and scarring.
Well, so here are my silly questions with that then. What are the symptoms of those autoimmune with that particular autoimmune disease? And then what are the treatments?
So the most common symptoms with those conditions would be itching and burning and just irritative symptoms. And depending on the condition, that can be limited to the outside skin, or it could even be, burning in the vagina. Uh, and the treatment for those conditions historically has been topical steroids.
Okay.
There are some non-steroidal medicines that we can use, and there are oral medications that we use as well if we have to. I try very hard to treat local issues locally, but sometimes the topical medications just aren't able to control the immune system in that area, and we need to use oral medications. But in general, it's topical. And while we're on that subject, one of the big misconceptions about topical steroids is that they will thin the skin.
Okay.
And so that misconception gets perpetuated frequently by providers. And I always think, if I could get all the pharmacists into one room in the world, and all the OBGYNs in one room, if I could say one thing that pertains to what I do, it would be, please don't be afraid to use topical steroids in the vulva and the vaginal area. Those topical steroids can thin the skin in some area, most areas of the body, but it doesn't thin the skin, at least not significantly in studies, in the vulvovaginal area. And we're trying to prevent cancer.
Right.
So even if I said to a patient, listen, this might thin your skin, it won't thin it significantly if it does, but it might thin the skin a little bit. They would take that over vulvar cancer, any day. So that's one of the issues I think that we face right now in treating women with these conditions is also taking away some of the misconceptions about the treatments themselves that perpetuate the suffering that the patient continues to have, and possibly even cancer and things like that. So
if women have been seeing all these other practitioners, what kind of stuff have they been doing for them then? They haven't been going for steroids.
A lot of, actually a lot of times, if the practitioner identifies the condition correctly, let's say lichen sclerosus, they may give them a topical steroid, right? But what they commonly will say is, use this as needed.
Okay.
For example, or you can use this for a couple of weeks, but then you need to stop
because they're worried about
the thinning of the skin.
Okay.
And this is, this is true, I believe, about all autoimmune conditions, is that to effectively treat them, you have to stay ahead of them.
Okay.
If you have rheumatoid arthritis and you only take your medicine when your joints are really hurting, then you probably are going to lose your joints over time, because you're always chasing the condition
versus prevention. You can't really prevent necessarily an autoimmune disorder, but you can anticipate or
you can treat an autoimmune condition so that you don't get flares.
Right.
So the goal of those treatments in general are to prevent flares, or when flares do occur, that they're ameliorated. They're not as intense as they would have been, and the frequency is not nearly what they would be without the treatment. So, if your immune system is flared up and it's attacking your tissues are being broken down to some degree.
Right.
So the least often that can happen is probably going to, end up being a better way for the patient, in the long run.
We talk about that even orthopedically, is for my patients with autoimmune, is learning their things, right? So if you need to stay hydrated, and you need to not be in the sun, and that this is how much activity you can handle, here are the things you can be doing to keep your condition, like activity modulation. You only have so many coins to spend per day. Don't go crazy, because then you're going to have this huge flare, and then it's all the lost recovery time. So
absolutely, it's preventative. Knowing, and it's a really good point too. Is that one of the difficulties with autoimmune conditions is that everybody's immune system is different. And so it is learning a lot of, how often do I need to use the medicine to stay ahead of it
for me,
for that. For you. Right. And so I always tell patients, well, the first step is just getting this under control.
Right.
And that is kind of there's no straightforward complete recipe for everybody, but there's a pretty good approach to that of how you get it under control to start with. But after that, it's a little bit of trial and error of, finding out with that individual, how often is their immune system going to go haywire?
Right.
And so, you kind of have to learn to play the hand you're dealt when it comes to immune issues.
Right.
Some patients can use, for example, a topical steroid once a week for their condition, and other patients have to use it every other day or every day, and that's a little bit of a something you just kind of have to figure out as you go along. So that's a challenge, as well. But what you can't do is not use anything.
Right.
Right. I mean, it just doesn't work well for autoimmune conditions if you just say, well, I'm just going to treat this as needed. Most of the time, that's not how we approach, other, most autoimmune conditions. So certainly in this area where I've kind of specialized, that's one of the educational things I always try to go over with patients is, even if you feel great, use your medicine.
Right.
And even if we were down to say once a week with your medicine, don't go less than once a week, even if you feel fantastic, because we're not treating just symptoms.
Right.
And
we're preventing flare-ups.
Yeah. And scarring and cancer can occur without symptoms in patients. So the safety of the medicines that we're using, not thinning the skin, for example, and understanding that it has to be used on a regular basis for your best outcomes is a big part really of educating or re-educating patients about the conditions that they have that I see on a daily basis.
Again, I from a physical therapy perspective, I have to spend time with patients saying, you will have this disc issue the rest of your life. Yep. I'm really sorry.
Yeah.
You need to do these exercises the rest of your life, even when you feel better.
Yeah.
Because a lot of times they feel better.
And then they stop.
And then we have a flare. And then I see them because now something else happened. And I'm like, now if you can keep your core, keep your glutes and do all this stuff, it'll be great. But if you stop because you feel great, then I'm going to see you later again for something. But I give you the tools, but you got to use them.
Yeah. That's true in a lot of areas of medicine. And it certainly is true in the autoimmune world.
And it is hard because there is that huge mental component of like, you just get tired of doing all the things. I know my patients are like, I don't want to do these exercises every day. And I'm like, give me 10 minutes, 3 or 4 times a day. So I understand the mental component.
Yeah, I agree with you. It's a tough deal to, anytime you have to explain to a patient, you have something that you're going to have the rest of your life.
Right.
I mean, it's true for autoimmune issues, for example. We don't know why they start in a given individual, and we don't know how to cure any autoimmune disease. So making that diagnosis is, I don't take it lightly, because I'm telling, because you're like when you're talking to your patient, you're delivering information to them that maybe they haven't processed yet.
Right.
This is going to be the rest of your life, but it's doable.
Right.
And it will make your life incredibly better. Your quality of life is going to be amazing if you do this. It'll be normal.
Right.
But if you don't,
then but again, I think a lot of people want to go back to where they just never had this, right?
That's what they want. Yeah.
So people are like, I wish I'd never had this, or I'm like, and I'm always like, mourn what you lost, but now you got to take what you have and let's make the best of it.
That's exactly right. I mean, and having said, I'm no different myself.
Right.
I want to have a metabolism that I had when I was 23 years old, but it's not going to happen. And, moving forward, I have to just know that, things change over time, and some of them just are going to be with us the rest of our lives. So I understand it is really hard, but it's definitely worth the effort in the preventative care to avoid really, really tough things. They're much harder than the initial condition itself.
What attracted you to working with autoimmune disorders?
I can't say that it was specifically I wanted to work with autoimmune, but what attracted me to this area in gynecology was when I was a resident and I came and sat with Dr. Davis in his office, and we always with new patients, we would have them come in and sit in an office and first before doing an exam and just kind of visit with the patient to find out why they're here and what the story is. And I think people are more comfortable talking, women are more comfortable talking, fully clothed than,
when you're like
half dressed in a gown and then trying to, provide information. And but I would sit with Dr. Davis and listen to the stories one after another of these women that would come in, and they would sit down across the desk from them, and they would say, I've seen four doctors for this, or 5 doctors, or 10 doctors for this condition. I've had this for 20 years, whatever the case is, and no one can help me. I don't know what this is. And he would listen to their symptoms, and then he would say, oh, I know what that is. I can help you. Right. And after I watched that happen over and over again, I was like, how does this guy know something that apparently the rest of us don't understand? And really what it came down to was putting the component of dermatology into a gynecology practice, which we generally don't do. And he understood enough about the dermatological conditions that occur that a lot of people don't even know exist and know what to do. And it was, patients absolutely, were they were so happy. They couldn't believe that anybody knew what they were talking about. And so there was an element of just validation. And I found that was even true even with the husbands. In my experience, a lot of times. So, for example, if a woman's been having pain with intercourse, that eventually starts to affect the relationship, and then there, I think in almost instinctively maybe, the partner starts going, was it me? Is this real? Is it not? I mean, we've seen other doctors and they say you look fine.
Does she just not want to have sex with
me?
She just
not want to have sex with me. I mean, whatever. And I think for a lot of patients, just having somebody validate this is a real organic physical problem and point it out. This is where it hurts right here. This specifically, this is the area that is really troublesome, and I know what that is, and we can fix this or whatever. But just validating the patient. When the husband's in the room hearing this, you can just sometimes even see the husband, like
be relieved.
Wow. Okay. It's validating for him as well sometimes to hear, that diagnosis, or that there's a plan, or that it can be fixed or whatever. So I think I love it when the husbands come in with patients, especially new patients. Because the patient doesn't have to go home and try to
explain,
regurgitate what I said, get things mixed up, and the patient and the husband hear it at the same time. I think it puts them on the same, on the same place mentally about how to approach what we're going to be taking care of. And to that end, I've used a lot of, not uncommonly, I'll have couples, especially, if they've been dealing with this together for a long time, see a sex therapist, to help them kind of further along, get back on the same page relationship wise. And I mean, if you've been having pain with sex for a really long time, even if I could snap my fingers and make you not hurt right now, walking out of my office, that patient is still going to have some apprehension, some guarding, some, and so
fear of it coming back.
Right. And I think too, the partner is afraid. Well, how long, is this a temporary fix? Is it
did I do this for them?
Was I? How do we get back as a couple back on the same page after we've been dealing with not being able to have sex for a couple of years? How do we get back into the swing of things? He doesn't want to hurt her. She doesn't want to hurt. She doesn't want him to feel blamed. He's been blaming himself maybe for, and possibly in part for it. I mean, there's just a lot of dynamics in that relationship that are affected by the chronic pain with intercourse. So so a lot of I do use a lot of fellow disciplinaries like pelvic floor physical therapists, as well as sex therapist, and not everybody needs those things, but it's nice when you can kind of identify those patients that would benefit from it, to have those specialists for me to refer to, to take care of those issues. I know about lichen sclerosus, but I'm not a pelvic floor physical therapist, and they are fantastic at that. I mean, you're a physical therapist, you know what you know.
Right. And that's why I love referring to my friends that do amazing in that area, because I do think it's important. I think that, sometimes there's an embarrassment that comes with that, and people don't want to talk about that stuff. And so, and a lot of times I'll have them they'll be working with their pelvic floor therapist on something, and I'm treating your shoulder, and, we coordinate together and whatever. But
yeah, it always kind of makes me laugh a little bit, because patients come here, first of all, they get here and they're like, you're a vulvar disease specialist? Like, that's weird. Right.
And because you're a male.
Or just it's just a weird specialty. Like, there's not a lot of us to do this.
Right.
And then they get here, and then I'm like, and now I want you to see a pelvic floor physical therapist. And they're like, well, this just keeps getting weirder and weirder. And I'm like, if you'll just trust me on this. And almost inevitably, patients, even if they're dragging their feet to the pelvic floor physical therapist, they come back and they're like, oh my gosh, she's amazing. Like, that made a huge difference in how I feel. And physically, I mean, it's just made all the difference in the world. And so it's a niche that people are unfamiliar with it.
Right. But I think a lot of people actually need it that don't know, because I feel like there's a lot of people just suffering.
100%.
And to me,
no doubt,
honestly, the experience you talked about when I first came here, I had my whole meeting in here with Dr. Davis, and he was like, oh, I know what this is. And it was nice, because at first I was skeptical. I'm like, what do you mean?
Most patients are,
because I've had 4 or 5 people just trying things on me, right? Back and forth between this doctor. So it was super nice to have them be like, read this article, and this is what's going on with you. And like, let's just take a peek, but your symptoms match this. And I'm like, what? So I feel like there's a lot of people suffering and just thinking they have to do this.
That is that's so true. I saw a study years ago now where they did street contacts, and it was like with women between 18 and 35, and it was like in Chicago, I think. But it was just street contacts. But in the study, they asked women, is it normal to have pain with sex? And the answers were yes, like 80%, something like that.
Okay.
I'm like, so I think that there's a cultural, belief to some degree, at least somewhere along the way. Girls, I think, they learn to expect that sex might be painful the rest of your life, or it's normal to have a little bit of pain. I don't. I'm just.
Well, I think we're taught it's painful when you first have sex, right?
Yeah.
And then I think there's supposed to be something where like women are just supposed to take it, right?
Yeah. No. I think there's some kind of culturally somewhere this gets taught somehow. I'm not sure where.
That, like, oh, it's I think in porn, in novels, and what I call like the women's smut books, right? They're always supposed to have like this man with this huge penis, and maybe it's painful, but the woman's supposed to take it because it's supposed to be amazing, right?
And the pain somehow is pleasurable, or it's all part of it, and so there's that component of I think culturally where there's maybe some. And this is just my opinion, unencumbered by data, as they say. But I do think that there's some element of that to some degree. But then that on top of not knowing, one, not talking to, it doesn't get talked about with friends sometimes because it's private information, and sometimes it doesn't get brought up. It's less so with the newer generation than the older generations of women. But and then also, even if you do say, hey, this doesn't feel right, and then you go to the doctor, And the provider says, you know what, you just need to have a glass of wine and relax.
Right.
Which I have literally had multiple patients come in and tell me that people have said that to them, or something similar to that. So it's really dismissive.
There's a lot of horror stories out there.
Right. There are. And like most things in medicine, we hear more about the horror stories than we do the good stories.
Right.
But there's enough horror stories to make you go, wow.
This is probably a trend.
Yeah, this is probably something we really need to do. We need to be better at this. And so when you have a combination of an innate belief that maybe hurting is pain is normal, you don't maybe discuss it with anybody, or if you do, it's with somebody else who goes, yeah, I hurt too. So
so you're like, I
guess that's a norm.
Right.
And then you go to a provider, and the provider gives you a very dismissive answer. There's a lot of stumbling blocks to getting better sometimes for women,
right,
with these kinds of issues.
And I feel like I think I told you I might make patriarchal statements, but I feel like for women in general, a lot of our things are dismissed, right?
There's
totally no
agree.
Studies on it. It's you're either hysterical, right. You need to smile more, just
right. Just have a better attitude.
Yeah, and, or this is just whatever. A lot of times for women coming in with symptoms and things like that, they're often blown off.
Yeah, because it's like, this is your biggest issue, is that you itch all the time.
Right.
Get over it.
Right. And I think we talked a little bit about, and I was going to ask, and I follow things on Instagram or whatever, whereas men's urological issues are covered.
Sure. Erectile dysfunction.
Yes.
Covered completely.
A pill and a thing and why, and then I've been seeing a lot on, because I follow this one lady on Instagram, and she's been posting a lot lately about not only how it's not covered, but a lot of what her frustrations are other doctors interfering in the treatment plan that she's doing, because they're like, no, don't take the hormones, or don't do the things that don't actually understand.
Yeah, that is a big problem, or it certainly has been in the past. I think we may be making some progress in this one area, and that would be the use of vaginal estrogen.
Okay.
We went a really long time, especially since 2002, when the Women's Health Initiative study came out, where there was disseminated, belief that estrogen caused breast cancer.
Okay.
And everybody was like, "Get me off them." Everybody was, "Get me off my estrogen."
Right.
Well, we've had 20 plus years now to look at estrogen and breast cancer. Speaking specifically of vaginal topical estrogen, the studies are clear that it does not cause breast cancer, and it doesn't cause a reoccurrence of breast cancer, even if you've had breast cancer.
Okay.
So, but when you have estrogen dependent tissue, particularly at the opening of the vagina, where most of the nerves are at, and you deprive that area of estrogen, or if you're on an estrogen blocker because you had breast cancer, that group of women particularly really suffered have suffered for a number of years, where, and this is the interesting about breast cancer to me, is we've gotten so good at diagnosing breast cancer, for example, and supporting women with breast cancer. And that's fantastic. I mean, that we need to make those kind of, steps, progressive steps in treating all cancers. But breast cancer, we've become really good at, I think, and making women aware, making sure they get their mammograms every year, improved imaging techniques with MRIs, doing all we can as a medical community to really step up our game in breast cancer. And then the treatments for that, we've improved. What we kind of lagged behind on was explaining to women what to expect after breast cancer.
Like, you're free.
Yeah, good news. You don't have breast cancer anymore. You're going to be great, no problems, but you can't have sex because, you're on an estrogen blocker, or for a long time, we don't want you to use any estrogen at all, because we don't want that, that could cause the breast cancer to come back, right? So they have, this woman who's been through the difficulties of breast cancer, have really kind of almost even maybe put it in a place in their life where it's not dominating their life anymore, right? They're on maintenance, whatever, if things are good, except for this one area, and that's where they can't have sex. So it's like breast cancer still has a little bit of a hold on your life.
Right.
It's impacting this huge part of your life. Great that you don't have breast cancer, but it also would be great to have sex too.
Right. And maybe that's where, again, where you're lacking, right? Like, here are the things that can happen. Here's what we need, the aftercare.
The aftercare. Yeah. And so I do think we're getting a little bit better at that. Just judging by seeing patients, that have had breast cancer that come to see me, versus, 10 years ago, 12 years ago. But, using vaginal estrogen cream, for example, and a lot of times with patients, I just tell them, if you'll just take a little bit, pea-sized amount, and just put it right at the vaginal opening, it'll make a world of difference, and so it isn't like, the patients are having to use an extraordinary amount of vaginal estrogen to get back where they need to be. And then we also have technology that was developed in the same time frame around 2014. CO2 fractional laser became available in the United States, and that became, in my opinion, like a godsend for breast cancer patients, because we finally had technology to rebuild the vaginal tissue to build it up in a non-hormonal fashion. And that became a real benefit to a lot of women. It may not have eliminated completely the need to use estrogen, but in a lot of cases it did, but it was really a big step forward for helping women who didn't want to use estrogen for whatever reasons, whether the reasons were valid or not, in the sense of causing cancer or not causing cancer. I understand if you had breast cancer,
it's just scary.
It is scary, no matter what. If someone says, "Hey, we want you to use estrogen," I can understand saying, "I would prefer not to."
Right.
Finally having something to offer them besides estrogen to get them back, able to have a relationship again.
What does the laser do? These are my
the CO2 fractional, it's a CO2 fractional laser. And basically, if you can imagine maybe the size of a postage stamp. And in that postage stamp, if there were about 100 little tiny holes, and lasers come out of that. So it's very, very, very small micro lasers. But what the laser does is it pulses into the dermis, or the deeper layer of the skin, and it causes a tissue injury response, basically. So it's activating the body's own healing abilities. So when that skin is treated with the laser, the skin recognizes that something has caused a micro injury there, so that the tissue will release growth factors, and those growth factors then lead to redevelopment of the thickness of the skin in the vagina, specifically, and it brings in new blood vessels, micro vessels, and so you can regenerate basically that vaginal tissue. They used to say rejuvenate, and then that became kind of like a hiss word, like don't say rejuvenate, because that connotated more like a tightening, cosmetic, maybe even a non-essential thing for women, not medically necessary. But it, for lack of a better word, it does cause that tissue to regenerate, in the vaginal tissue. So when you do that, then you can hold more fluid. The vaginal tissue is kind of like a sponge. It holds a finite amount of fluid in that tissue that you need to have comfortable intercourse, for example. And just like if you took a sponge and you cut it in half, you can't hold the same amount of water in that sponge. The vaginal tissue, when it thins down, you can't hold as much fluid in that area, and so it gets drier, and then it's just really uncomfortable. If you can rebuild that tissue so it can hold a normal amount of fluid and be the full thickness of skin, that the nerves are underneath that tissue, they don't want to be exposed to thin skin. That's uncomfortable. So it's just kind of a way to regenerate that vaginal tissue without using estrogen.
Is that something you would do for anyone even just going along through like menopause?
Yeah. What's interesting about that is that I got the device in 2014 because I was seeing so many patients that were coming to me saying, I had breast cancer and that's great. It's behind me now, but I can't have intercourse. It's too painful. And then I got the device, it was, like I said, it was like a godsend for those patients. But what evolved over time was that it was helpful in patients that hadn't had breast cancer. It was helpful in menopausal patients. It was helpful in patients with autoimmune conditions, even. Lichen planus is an autoimmune condition that can affect inside the vagina. Essentially, it thins the vaginal tissue. The immune system is is attacking the vaginal tissue, and it becomes very thin. Just using the Mona Lisa laser, which is a CO2 fractional laser, using that in the vagina, to me, intuitively would make sense because it does the opposite. It wants to build up the tissue. So we started using it in patients with lichen planus and got great results. Okay. So does every patient with lichen planus need to have the CO2 fractional laser? No, but it's potentially a really good adjunctive treatment to rebuild, the normal vaginal thickness of the skin. And so it started, we started seeing other applications for the CO2 fractional laser besides these breast cancer patients. I know even urologists have used it as well for some of the things that they treat, and so it's definitely has expanded its use over the years of what it's useful for. And I think that anything you can find adjunctively to add to what we're doing to help these women with these chronic, conditions is worth looking into. At least look into it and see if it's something that would work for that patient. But platelet-rich plasma, CO2 fractional lasers, those kind of things have been used now in these autoimmune conditions that we treat vaginally, and in non-autoimmune, issues. So I think one of the things that has been I've been happy to see in my career has been when I started in my career, it was vaginal estrogen. Okay. Right. For vaginal dryness. Right. Painful intercourse, whatever. And in my career time, which is, basically 20 years, let's say, I have seen some things change. Right. Or progress that hadn't changed for 50 years. Oh, wow. Okay. I mean, leading up to that, vaginal estrogen was the answer for decades. Okay. Without really any other options. Right. Now we do see things like these things I've mentioned, but also like hyaluronic acid, and different forms of estrogen than what we traditionally used. And so there's no question there needs to be a lot more done in terms of women's health. And kind of getting back to your original question, I think, we have to do so much better at funding studies for women's health and educating doctors and providers about things that we haven't traditionally, like maybe teach some more dermatology in OBGYN residency, right? Just for example. But thankfully, we have seen some progression, in a lot of areas, and so hopefully that continues. It's just not enough is done,
Well, hyaluronic acid, what do you use that like generally? Just
so hyaluronic acid is basically
I see all the skincare commercials for it.
So. Yeah, it's able to it's a non-hormonal, basically it's a non-hormonal way to try to plump up the vaginal tissue in this scenario. To be perfectly honest with you, I don't use it very much. Okay. Well, I know it's out there and a lot of women do use it, but it's a moisturizer. It's a way to provide a little more moisture in the vagina, and it's hormone free, and so that's appealing to a lot of women, that don't want to use hormones. But again, if I could just kind of reiterate that the safety of hormone replacement therapy, if you look at the studies and you don't listen to maybe a friend of a friend and a cousin, that had it, there's a real feeling. Number one, vaginal estrogen does not cause cancers. All
Right.
right. I mean, they're rarely a uterine maybe issue, but it doesn't cause breast cancer. It can be used in women that have had breast cancer. I mean, that alone is a big step in the right direction. But even systemic hormone replacement therapy, there was such a time when everybody was so afraid of it. And still there's a stigma, I think, a lot, but really, if the current thinking right now is that, estrogen, systemic estrogen, may not cause cancer like we thought it caused cancer, for example, in the breast, but it might promote that a cancer that does occur. Okay. Right. It could, but in and of itself, is it causing breast cancer? You know, I don't think that feeling is quite as like it was a few years ago, that it actually causes breast cancer. You know, but it definitely is hormone replacement therapy. It's going to be controversial. I get that, but I think a lot of women suffer needlessly because of things that they're afraid of that aren't actually proven. It's just things that they have heard, and then been passed around. If I ask a patient, what's the biggest risk of taking systemic estrogen?
Right.
Almost every time they'll say breast cancer, and I tell them, actually, it's not. Your biggest risk is a blood clot. Oh, okay. Right. So when you look at the label on estrogen and it says, may cause heart attack, stroke, DVTs, blood clots. Well, that's a legitimate, thing. Now, does it happen very often? No, it doesn't. But that's a bigger risk than you getting breast cancer. Right. So, but women, study that scared the whole generation of women away from estrogen, which was interesting because that was in 2002, and I finished in my residency in 2006, and so I saw this whole thing happen as I was finishing my residency and then going into my fellowship and practice, and I saw women come in and say, "Get me off this estrogen. I don't want to be on estrogen. I don't want to get breast cancer." Right. And then 3 months later, show up and go, I need the hormone. I want my estrogen. I don't care if I get breast cancer. I'll beat it, because I can't live like this. Right. And so it's been interesting to watch that kind of evolve. But I think we're moving in the right direction with hormone replacement therapy in terms of really getting down to like what are the actual risks, and so patients can have a better idea of what risk am I taking by doing this, because in general the quality of life is much higher. Right. When they're happy. Yes. And sometimes women don't realize the benefits of estrogen aren't just for hot flashes and night sweats and brain fog and things like that. It pertains to their bones. Nothing prevents osteoporosis better than estrogen. And estrogen helps prevent plaque buildup in the cardiovascular system. And so sometimes we overlook the fact too that even though let's say that there's a small risk of you having a blood clot if you're on systemic estrogen. Right. And so you decide not to go on that estrogen. Then your bones thin out. And then later on in life, when you're 70, and for a lot of women today, they're still playing golf at 70. They're still very active, playing tennis. They look, but you break your hip. Right. Well, guess where you get a blood clot? Is after a hip surgery sometimes, or being immobile, recovering from surgery, and then you got. So it's like sometimes you have to take the big picture and go, whoa, okay, what is the risk of me taking this? And because if the risk of not taking it is even a risk of the same thing I'm scared of, right? Then maybe I do want to think about taking this to prevent that other risk down the road. Right. You know what I'm saying? So it's hormones are really it's such a it's an interesting area of medicine to me in the sense that it's very philosophical. Right. Okay. I mean, if you have high blood pressure, well, there's not a lot of debate about, and at least I'm a gynecologist talking about high blood pressure, but I mean, but I'm saying there's some things that it's just like if you have high blood pressure, you probably need to take one of these pills. Right. Or I have my own issues with blood pressure medicine. Yeah, or you need to change these things in your lifestyle, right? Right. Like there's not one doctor going, well, I don't think you need to exercise if you have high blood pressure. And another doctor saying, yeah, I think you should exercise with high blood pressure. That's not really debatable. But with hormones,
everybody has their input.
Everybody does. So it's still very philosophical for provider to provider. But I think the best you can do as a patient and as a provider is just well, the latest studies, the best studies we have available, the best information we have show that A, B, and C.
Right.
Make sure the patient knows that so they don't get misinformation from somewhere. And maybe they can even inform somebody, of that. But so they can make a choice because that is logical, safe for them, and improve their life without assuming a big risk of something or afraid of a risk that prevents them from having a better quality of life. So.
Well, and it's interesting you say that because that was what the posts were talking about, was where they were like, here's this area of medicine where every doctor feels like they should have an input on it, right?
Yeah.
Whereas you wouldn't be like, they shouldn't be. I mean, again, doctors should communicate. And if someone was on a medicine that might interfere with whatever, but in general, you'd be like, okay, they're managing their blood pressure, right? But everyone seems to think that they're going to have their input on this person's hormones.
Yeah, that's exactly right.
And that's what they were.
It's very tough.
Expressing frustration that they're like, I'm on this treatment plan with this patient, we've discussed it, and then they go see their primary, and the primary is like, you shouldn't be on this.
Yeah, you should be on that.
And then changes their stuff, and then the patient goes all freaked out. And so it is interesting because that's that piece of the pie everyone thinks they should offer.
Yeah, you're exactly
right.
Even
with less education in that particular area.
And recently I had a patient that I recommended she go on hormones. She had cancer in the past. I don't remember exactly what kind of cancer it was right now, but I said, the benefits far outweigh the risk for you to be on estrogen. Right. And she went to our primary care doctor, and the primary care doctor was like, oh my God, what are you doing? Like, you cannot be, I can't believe that anybody would put you on this estrogen. So she said, well, I think she had an appointment with her oncologist, and she was our oncologist. And the oncologist was like, yeah, that's no problem at all. You should be on that estrogen. The benefits outweigh the risk. Well, I mean, she came, so when she came back and saw me, then finally she was like, you were right. I feel for patients because it is really hard to be between two doctors that are telling you the opposite thing to do.
Right. And then you have to kind of make your decision and fight for what you want. Right.
Yeah. So, I mean, the best you can do as a patient, I think is do your research, be your own advocate and look and do what you're comfortable with. And even if the studies say one thing and you just aren't comfortable with it, that's okay.
Right.
But at least you're not making a decision out of just pure fear. That an uneducated decision.
Well, and it's interesting because again, I feel like even some of the primaries that I've talked to talked about how they don't get a lot of education in this area for women in school anyway, but they are given that one study to be like, no,
it freaks everybody out. And I have the utmost respect for primary care doctors. My brother's a primary care doctor, and I think a really good primary care doctor is probably one of the smartest doctors out there because they have to know so much about so many things.
Right. Like the gatekeeper to all the things.
But for, the primary care doctors, we're so scared off of hormones, I think, from using them. And there's also this feeling of, well, I don't want to give somebody something, they have a blood clot, and then I get sued for, there's the medical legal aspect of these things, where you're covering your rear end as a doctor, so you feel like, and and from the oncology standpoint, I think for many years, it was just no matter what the studies may have said, or even, whatever the case was, it was just easier to say no. Because
it was safer.
Safer for the doctor.
The patient may suffer these other things. But the doctor knows that they're covered.
But the doctor's sleeping well at night.
Right. They're not they're like, I didn't let him get cancer.
That's right. Yeah. I'm not gonna get sued, because something bad happens.
As a contingency you got to think about.
It happens, but unnecessarily a lot of times, and the patients are the ones that are actually suffering, Right. So even if I'm sleeping well at night, but I'm not giving you the best treatment, that's not good medicine. So you really I think in hormone replacement therapy, in that world, I think we're making some progress there and getting better educated ourselves as providers and helping patients understand too. But I think we're going to see a swing, continue to see a swing away from fear of estrogen in the cancer arena as much as we have had in the past. And I'm not saying there's no relationship between estrogen, systemic estrogen, and breast cancer or cancers in general, but I am saying that it may not, we may fine tune where we need to be afraid and when we need to be afraid to use that, or think we shouldn't use it, versus just a blanket no, we should never use estrogen because it could cause A, B, and C.
Right.
Because for women, estrogen is just such a key component to the quality of life. And if it was 1800s and life expectancy is 43 years old,
so you wouldn't need to be worried about
nobody
menopause.
had to deal with menopausal symptoms, right? This is a 21st century issue that we're still learning about is providing the best quality care for women from a hormonal standpoint in the safest way possible.
Right. It is interesting when you say that, because a lot of times people are like, but I have this and I have this. I'm like, technically you probably shouldn't even be alive,
Right.
Back before, like, we didn't have to worry about what it was like in our 80s and what our joints and our things were doing. So now this is why we're learning all these things. So that makes sense that now we're trying to figure out what happens.
Yeah. I mean, as life expectancy increases, new problems we face that we never faced before, that we have to now learn how to
work with our bodies.
Yeah. How to treat it and take care of it. And we had talked earlier about just the state of healthcare in general.
Right.
And I just wanted to just touch on that real quick, if that's okay.
Yeah, that's perfect. I was going to head that way.
I think we live in a very adversarial culture when it comes to our healthcare. Right now, everybody is very, very happy with the healthcare situation, except for providers and patients. And that has to change. I think the pharmaceutical companies are extremely happy with the way healthcare is going in the United States. I think insurance companies are very happy with the status quo, but providers are very frustrated, and patients are extremely frustrated, and all of us are patients. I'm a provider 8 to 5, but I'm a patient too, and so I know that frustration. I'm on a blood thinner, and I went to get the blood thinner the other day, and for 30 pills, it's over $500. Okay. $500 for 30. But that's if I have, that's because I have private insurance.
Right.
If you have Blue Cross Blue Shield, Aetna, Cigna, one of those, it costs $500.
Right.
If I didn't have insurance, I can go on a plan provided by the manufacturer, and it's $5.
Right.
Okay. That's there has to be some.
It probably costs like 10 cents to make that.
Yeah. And I don't know this for a fact, but I would imagine that they may be selling that same drug in Canada or other countries for significantly cheaper, So anyway, my point is just that I get it. I'm a patient too. And on the provider side of things, I have dealt with insurance companies. I dealt with them for years, and they were, geared towards preventing payment. Yes. Insurance companies want to receive premiums and pay out as little as possible.
Right.
That's their business.
They stay in business.
That's their business model.
Right.
And I absolutely hated working with insurance companies, dealing with insurance companies. I mean, for every dollar I might have made as a doctor, it was, number one, it was a fraction of what we probably should have received, right? But by the time you are paying an office employee to be on the phone with the insurance company to do the resubmissions because the insurance said it wasn't filed correctly, to get all the paperwork, to cut through all their paperwork, to go through a middleman who looks at the submission before it even gets to the insurance company, and they take their cut out of the. By the time you get back what you billed, I mean, I was getting 30% of the billable,
Right.
and the point is not woe is the doctors, but there is an element of frustration to have an insurance company deny, underpay, work against you. Everything right now is working against us as patients and providers.
Right.
But it's so adversarial.
And it does pit us against each other,
right? It does, and so I think, this is just my opinion, but I think we're seeing a little bit of a revolution in our healthcare system. I think things are going to change. They have to change it. They have to change. Something has to give, because we're going to see, and we are already see less individuals interested in going to medical school.
Right. Because of all, I mean, look at all the stuff you got to go through.
Well, to give up 10 years of your life, your 20s and your 30s,
right,
to come out to not get paid, but be in debt, $300,000-$400,000,
right,
to work maybe really long hours, or to be in high pressure situations, maybe, whatever the case is. That is not inviting. Not many people in the world are going to go, yeah, that sounds like a great plan, I'd love to do that.
Right.
So I mean, we're not going to see people going into medicine and in all fields. I mean, physical therapy. I mean, I know for a fact, I just talked to a physical therapist, and she was telling me, with Medicare, the difficulties that they have with Medicare billing, and it is insane.
Right.
It's absolutely insane. I when I stopped taking Medicare, and Medicare said, well, your patients can't submit. If they see you, they can't submit to Medicare out of network, or on the side, because you're not on Medicare. And they can't submit to their secondary, because if Medicare doesn't pay first, then their secondary isn't allowed to. Okay. Which I also think is
below. So they would rather screw the patient over.
Yes.
Essentially.
And I can't remember specifically what she said, but I think it was that they can't, that Medicare patients can't use the cash out of pocket to see her as a physical therapist. And I'm like, how can Medicare tell you where you can spend your cash and can't spend your cash?
Right.
If I have $100 in my pocket, you're telling me, and I want to go see a physical therapist, you're telling me I'm not allowed to spend $100 to see the physical therapist? My first thought was, well, how would they know?
Right. Touché.
But she said that, right now in their situation, Medicare patients, because they aren't contracted with Medicare, are not allowed to come see them and pay cash to see them even.
Wow.
No. I mean, it's just, you just hear these stories one after another.
Where the insurance company would rather the patient get screwed over.
Yeah.
Than, heaven forbid, that money goes somewhere else.
Yeah.
Or someone gets a quality care because they're not trying to have to churn and burn, right?
Yeah. I mean, and there's on TikTok, there's some really good docs on TikTok that talk about, and one of them was an ophthalmologist, and I can't remember his last name. Anyway, and then there's a plastic surgeon doctor who's really kind of gotten a lot of notoriety recently, because she recorded her phone call talking to the insurance company about getting a peer-to-peer phone call.
Right.
And it's funny because years ago, I've had the experience of having, setting up a peer-to-peer phone call with the insurance company because I wanted to do something for a patient, a procedure or something. And getting on the phone with another doctor representing the insurance company to determine whether what I wanted to do was plausible and should be covered or not. And I was on the phone with this doctor from one of the insurance companies, and the procedure I was going to do was called a vestibulectomy, where I take out some tissue at the opening of the vagina for painful intercourse and things like that. And the doctor got on the phone and said, why are you doing surgery in the ear if you're a gynecologist?
Oh, shit.
And I said, what kind of doctor are you? And he says, I'm an ENT. And I said, so I'm a gynecologist, And then they want me to have a peer-to-peer with with ear, nose, and
they didn't even
throat.
understand that it was an actual
Because
gynecological procedure.
right,
Mm-hmm.
the only vestibule that they knew about was in the ear.
Okay.
So I said, well, you made this come as a shock to you, but there's more than one vestibule.
Right.
And you know, so those kind of things are so frustrating because the insurance companies are not really trying to help the patient or understand the provider's point of view on why we want to get something done for the patient. They're just trying to find a way to not spend money on the patient,
Even me, when I have to have peer-to-peer, when I would do that with therapists, right?
Right.
And they're like, oh, it's low back pain, 5 day visits. And I remember talking to one of the therapists and I said, I don't mean to be a dick, but like, when is the last time you treated a patient? Could you get this person done in this period of time? They're like, oh yeah. And I'm like, well, when's the last time you were in a clinic? I understand we all want to pay our bills, right? So you have this job and you're following an algorithm and you're just handing out the shit, right?
Yep.
I don't think you've treated people in a long time. So how do you actually know? But you're following this algorithm and you're giving me what
checking
I get.
Boxes.
And I know if I piss you off, you're probably going to give me less boxes. But like
yeah.
But at the same thing, I was just like, really? And I'm not trying to milk the system. I'm just trying to give the quality of care that I think the person needs.
Exactly. And I went through years where the insurance companies would come back after I would do a procedure, and they would say, well, this is cosmetic, so we're not going to pay for it.
Right. And then your stuff was all denied, and then
and everything's denied, and I just wouldn't get paid for surgeries. And I'm like, hey, I can provide the pathology report that shows that this is a skin condition. This is an autoimmune skin condition that required this procedure. And you're just met with, we still think it's cosmetic. We'll have we'll reevaluate it. We'll do a peer-to-peer, do a peer-to-peer with somebody. On the phone, they would say, oh, I understand now why you did that. That makes total sense. I'll take this back to the committee, and then we'll send you a letter and let you know. And then it's still the letter comes from the committee a week later, and they're like, we still won't stand by our decision. That's a cosmetic procedure. And I'm like, it's like so frustrating that so anyway, the state of healthcare miserable. It has to change, right? For all of us, for the provider, for everybody in this providing care in medicine, doctors, nurses, physical therapy. I mean, everybody involved, right, is getting really discouraged, and I think in getting the short end of the stick. And patients, even worse, are the ones that ultimately are really suffering from it. Right. I mean, I know that no matter what happens with your patients, let's say, you're still going to provide the best care for them, and you may not get paid for it, right? You probably are going to get paid less than what you're worth, but in the interest of the patients, because you're in it for the patient to get them better, and you're willing to do that because you're a provider. That's why you went into this. And I think a lot of providers feel that way, right? I know lots of providers, including myself, that are willing to provide care for free sometimes, or at a very reduced rate, because I know where else they're going to go, or they really need the help, and you're willing to do that. We're trying our best to most providers are trying their best to help patients out, but
and patients probably don't even realize.
Maybe not, I don't know. I mean, I know some do, because, they say thank you, and they express a lot of gratitude and things, right.
And you don't do it because you want the immaculate. No, you do it because it's the right thing to do.
It's the right thing to do. I always think, well, is this my mom? What would I do? This is my wife, and what the situation is. But still looming in the background is this dark cloud of greed and misappropriation of money, and denying by the big pharma and the insurance companies, and frankly, I don't think that they have our best interest. Personally, I don't think that they're the ones going, what would be nice? We really should lower the price on this, because people really need this medicine.
Right. We all know it's bottom line.
$500 seems like too much money for somebody to pay to not get a blood clot. We should lower the price on that, because that doesn't happen. They're not interested in this, best thing for the patient or provider. So I'll be interested. I'm interested to see what happens in the future. I do think it's we're seeing some changes because I think enough people are providers, included, are really saying, "Hey, we're done with this insurance thing," and a lot of
Right.
providers are getting off of insurance entirely, and
Right.
just saying, "Well, I can't live that way,"
Right.
and it can work. It can work for providers to do that, but what if everybody on Blue Cross Blue Shield just stops subscribing to Blue Cross Blue Shield? Well, they finally get their attention, but I know that's not really
Right.
feasible. But
I'm
I
not sad about that kind of revolution, but yeah.
yeah, right. I mean, if we could have a revolution, this is the one to have.
Mhm.
Is to get things back on track with our healthcare system. But anyway, I just wanted to just
No,
express
you're
that
just saying a lot
frustration.
of things that I've always said where I try to break down for my friends because I end up encountering a lot of people that are like, but I have good insurance. And I'm like, eventually, no one is going to take it.
Hmm.
You can have the best insurance in the world, and all of these providers are basically tired of being screwed,
Yeah,
and no one's going to take it.
yeah.
And so, and again, there are people again that'll churn and burn, but then don't bitch about the quality of care you get.
Yeah, right, exactly. Because
Mhm.
if your reimbursements are just,
Mhm.
pitiful, then it
Mhm.
becomes a volume-based business.
Yeah, and then you get them in, you get them
Get
out,
them out.
and we all have to pay our bills. And I've had friends that have, they try to work and they're like, I have 15 minutes to see a person, diagnose them, do the note, and move on to the next.
Yep.
And
And the patients feel that,
mhm.
and combine that with electronic medical records, and now the
Mhm.
doctor doesn't even, and the provider doesn't even look at you in the room
They're
because
typing
they're
the whole
typing the
time.
whole time.
That's basically how it
Hey,
is.
your 10
Yeah.
minutes is up, ding, you
Right.
got to go because I got somebody else to get in here. And so, those are the kind of things that just affect the quality of care that we provide. And
Right.
it's not that the providers would like for it to be different, it's that they have to work within the system for gainful employment.
Right.
They
To
have
survive and
families,
pay their own bills.
yeah, they have families to
Mhm.
feed and things to do, that
Uh-huh.
they have to take care of. But I hopefully we'll see it change. Hopefully in
Right.
our time in practice, we'll see it get
Mhm.
better. I hope it does. But in terms of women's health, we need to, hopefully we'll see more funding go towards women's health and more
Mhm.
research in these areas, and especially areas that we just don't know as much about, like
Uh-huh.
autoimmune conditions and how they affect women. There's just not enough. There's an organization called the ISSBD and another one called ISWISH, ISSWSH, that have spent a good amount of money and time and
Uh-huh.
looking into and doing studies, providing information, education for women with a lot of these conditions that I deal with and treat. And those are good organizations to look at for some information, but they can't do it by themselves. ACOG really should be more involved in in these skin conditions, for example. Uh,
American for
American College of OBGYN, they really, in my opinion, they don't spend enough time, you know, looking into the dermatological aspects of gynecological care, and as you talked about earlier, the numbers of women that suffer with these things is vastly underestimated. I mean, I have a clinic that has gone for over 30 years seeing nothing but patients with these kind of problems
right.
every single day. And, so it's not that the conditions don't affect enough, enough women to warrant,
Right.
spending the money to look into it.
Right.
I mean, it's that we haven't been good enough at diagnosing and managing and understanding there are the conditions.
Or looking into another thing that affects women.
Yeah. And
Yeah.
so, it's like it's hard to justify not spending money on something that because you don't think that it's an issue
Right.
when it really is,
Or it's not as important
or
as
it's not as
erectile
important as
dysfunction.
erectile dysfunction.
Mhm. Yeah.
And so the disparity is there, it's still there, and that needs to change. It really does. And
Uh-huh.
I hope hopefully it will,
Mhm.
bringing the light information about these conditions and that there's
Right.
help and there's treatment and things like that, only helps to get more attention, shed the light in the area where, maybe in the dark corner where it's been hidden. And so, this kind of thing, just talking about it and putting it out there, I guarantee you that, there might be somebody who listens to this podcast and goes, oh my gosh,
That's
I have
and that's
lichen sclerosus,
honestly,
I didn't know anybody knew about that. But
I mean, I do try to refer and stuff, but that's honestly why I wanted to talk to you because I do want to highlight why you do because I think it's important. And I think it is nice to have that where someone's like, I know what this is, or
yeah,
that works in that kind of area where not a lot of people specialize. So
Right.
again, when we get it all live, we'll have the resource, like a link to your guys' website, and it'll be on our website. So
Sure.
link people to be able to find you. So
Awesome. Well, I appreciate it because
Mhm.
there are so many women out there who could use a little help in an area where they didn't think there was much help. And I always tell patients too, if I can't help you, I will find somebody that can. I
Right.
mean, maybe I have a network that a lot of people don't maybe have it at their disposal, where I could get help from other specialists from around the country, to help
Right.
out with things. So and I love seeing patients come in that have been, finally given a little bit of hope, or they see a little bit of hope, or when they leave the office, they have a little bit of hope that maybe this is going to get better.
Right.
And maybe they're going to finally be heard. And that means the world to me, and really my staff and everybody. That's really what we strive for every day. So thanks for letting me talk about a little bit about this little area of medicine that people don't know about.
But it's very important. So I appreciate your time, and we're going to sign off from there.
All right. Thank you.
Thank you for listening to today's episode. As always, whether we're listening to someone share their expertise in treating an area or just sharing their patient experience, we have also listed any of the resources or how to get hold of the practitioners on the resource page of the website for betterfittherapy.com. Always follow us on social medias, Instagrams, Facebooks, for more information. Feel free to reach out or message if you would like to contact or you have additional questions in an area. And again, thank you for listening. We hope that you gained something from today's episode, and we'll see you next time.